Hi, everyone, and welcome to today's program. So glad you could join us for the topic of latest treatment options in Hodgkin lymphoma in 2024. I'm Stephanie Trong. I'm the founder of The Patient Story. More importantly, though, I went through treatment for lymphoma as well, although it was non-Hodgkin lymphoma. I do believe, though, that we have shared experiences and questions after a cancer diagnosis, and that is what The Patient Story is all about, helping navigate people after a cancer diagnosis when there's so much overwhelm and a lot to wade through. And we do this through conversations with patients, care partners, and top cancer specialists like the incredible people you'll hear from in just a moment. First, though, we're hosting this in collaboration with our friends at the Leukemia and Lymphoma Society, or the LLS, and Immerman Angels. The LLS is the world's largest nonprofit health organization dedicated to funding blood cancer research. It provides a lot of incredible resources, education, and services. For example, they're information specialists who are just one phone call away to help with your questions. Also, Immerman Angels, a wonderful organization with a peer-to-peer program that's supportive. They'll connect you with other patients and care partners. I was a support seeker myself with Immerman when I was going through treatment and became a mentor after. So before we begin, we also want to give special thanks to Seigel, now a part of Pfizer, for its support of our educational program. Their support helps us provide these independent programs, which are free to our audience. I do want to say that The Patient Story, the LLS, and Immerman Angels retain full editorial control over the entire program and all content. And while we hope you walk away with better understanding and knowledge, please note that this is not meant to be a substitute for medical advice. Lastly, what you think is really important to us. Was this helpful? What do you want to ask? Let us know in a survey that will take just a few minutes and that will pop up right after this program. Okay, that's all done. Now to the moderator for this discussion, a physician herself, as well as a Hodgkin lymphoma survivor who went through treatment multiple times, Dr. Sam Seigel, whom I'm lucky to call a friend now. So Sam, Dr. Seigel, thank you for leading the discussion, and I will pass it off to you.
Thanks, Stephanie. My name is Sam Seigel, 2 times Hodgkin lymphoma survivor, BMT survivor, and primary care physician doing survivorship medicine. And I'm here today to have this wonderful conversation with Dr. Natalie Grover and Dr. Stephen Ansell about Hodgkin lymphoma updates. We're here with Dr. Natalie Grover. She's a hematologist-oncologist with UNC School of Medicine. She's the clinical director of Cellular Therapy Program and leads several CAR T clinical trials in lymphoma. Strives to improve treatment options and quality of life for lymphoma patients. Dr. Grover, can you just tell us a little bit about yourself and what drew you to lymphoma and kind of a little bit about your approach with patients and how you care for them?
Yeah, absolutely. So when I started fellowship, so I guess going way back when I was a maternal medicine resident, I realized that I was drawn to oncology. A lot of it was based on my relationship with patients that I saw when I was taking care of the patients on the inpatient oncology ward, and I realized that I always, when I saw those patients, I wanted to go back and find out more about what happened to them and really form those connections with them. And the other part of it was that there were so many growing new discoveries and new treatments available. Even during residency, the treatment landscape was changing so much. So that really drove me to oncology. And then the other part of it is I really like how heterogeneous lymphoma is and involves a wide patient population, both young patients and older patients. Is really truly systemic disease. And and there's so many different types of lymphoma. It's more aggressive, more slow growing. So my clinic is always a very heterogeneous clinic of different patients that I see. So I really enjoy that.
Yeah, that makes a lot of sense actually. That lymphoma is sometimes this umbrella that it's one thing, but it's actually like a lot of
Yeah.
different diseases and can affect multiple parts of the body. And yeah, I could see how that's super interesting. Well, thanks for sharing that. We're also here with Dr. Ansell. Dr. Stephen Ansell is a hematologist oncologist at the Mayo Clinic, studies and specializes in Hodgkin's lymphoma. His research has led to the use of immune checkpoint therapy in lymphomas, which is very exciting development as well. And his goal is to translate his research into new treatment approaches. Dr. Ansell, can you tell us about your path into lymphoma and what drew you to that field and your approach with patients?
So thanks so much, and really exciting to be part of this discussion. As you can hear, I speak funny, so I came from another part of the world. I trained in South Africa, and I sort of landed in oncology almost by mistake initially, where I was very focused on internal medicine, but they needed someone to do some work temporarily in oncology and kind of assigned me to that. When I got there, similar to Dr. Grover, I really was excited about the opportunity, the disease, and then also the patients and the ways in which we could really make a difference for patients based on the fact that treatments were really highly effective and beneficial. Even initial treatments back in the days of more chemotherapy, actually a lot of patients benefited substantially. And I think the thing that has really been exciting for me over the course of my career so far has been to see how we can change treatments in a way of increasing the number of people who benefit and are hopefully are cured, and decreasing the side effects and toxicities by being able to find effective therapies that aren't that hard on patients.
Absolutely. And your areas of interest and passion are so personally meaningful to me and my individual lymphoma walk, and I think will resonate with a lot of people who are watching this. So after I was diagnosed with Hodgkin lymphoma, I was diagnosed with stage 2AE. And the reason that all those letters and numbers are important is because E meant extranodal manifestations, that I had some lung involvement. And so it was kind of confusing whether or not I was stage 2 with just right around the lymph nodes in that lung or stage 4. And the reason that was important is because it was going to impact how many months of chemotherapy that I had. So I ended up having 6 months of ABVD. I actually had 2 months of ABVD. And then my cough improved pretty quickly, my initial cough that I had at the time of diagnosis after 2 months of ABVD. And then towards the end of that 2 months, I started getting a cough again. And then my PET scan looked really good. And so the thought was that bleomycin was probably to blame for that cough. So we dropped that bleomycin, and it felt pretty okay making that decision. And so then I went ahead and I finished the remaining 4 months of AVD. And I felt pretty rotten at the end of it. Even though my end of treatment PET scan was clean, I was really run down. I had gained a ton of weight from steroids, a lot of brain dysfunction and kind of overall body pain. And I didn't really know what was to blame for that. Was that just because that's how a body feels after it's been through 6 months of multi-drug chemotherapy? Or if there was something else going on. And then in about a month or two after that, I developed symptoms that were eerily reminiscent of my initial diagnosis. So wheezing just in the left upper side of my chest, which at that point I knew, okay, that's not normal, just up here. And then also about a pea-sized lump above my collarbone in a very similar location to where the initial lump was. It was kind of a process to get the tissue to confirm that relapse. I had to have 3 biopsies, and ultimately the third one was a thoracic surgery to get a lymph node that was right near my heart in order to confirm that was a relapse. So by that time, because I felt so beaten up by the traditional cytotoxic chemotherapy, there were sort of new studies or new information coming around about salvage therapy, which is the therapy after a person has relapsed with initial therapy. And I just, at that time, did not feel that I could go through another few months of multi-drug traditional cytotoxic chemotherapy. I felt really beaten up, worn down. And so there was some data coming out about brentuximab, an antibody drug conjugate, or sort of like a smart chemo, and using that as a bridge to stem cell transplant or autologous bone marrow transplant. Those are the same thing. And so my oncologist said, "Hey, these trials showed that this could be an effective bridge to transplant. What do you think?" And I said, "Heck yes! Let's go for the therapy that has the least amount of toxicity." And even though I had some side effects from the brentuximab at the highest dose that I first started it on, it still felt like a cakewalk compared to my initial drug regimen. That just goes to show how important the science is, the clinical trials that inform how we adjust therapies, especially therapies that were really sort of traditionally, pretty toxic, long-term toxicity and late-term effects. And how about Dr. Ansell? Could you tell us about some current standard treatments and their efficacy for first-line Hodgkin lymphoma?
Yeah. Hodgkin lymphoma, I think, in many respects, as Dr. Grover and I are part of a treating team, we think about it in sort of 2 buckets, if you like. People that have more limited stage disease, so in other words, disease only on one side of the diaphragm, either above or below, or more advanced disease where it's kind of both sides of the diaphragm or in the bone marrow or in other tissue. And within the limited stage, one side of the diaphragm, we think again of 2 buckets, those that have favorable factors, and these are different symptoms and other tests that we might do that are what we call prognostic factors. If you have favorable prognostic factors, we treat you with really very minimal chemotherapy. More advanced, but more symptoms and unfavorable factors, we would treat you with a little bit more treatment, and advanced disease with kind of like more treatment yet again. And so what does that exactly mean? There are always ways in which we're trying to make the treatment better, but the most standard way is if you have very limited disease with good favorable factors, we often will just give 2 rounds of chemotherapy treatment and we'll consider consolidation radiation treatment. If you have more advanced, a little bit more advanced, but still limited, one side of the diaphragm with more unfavorable factors, we would give more chemotherapy, like 4 rounds, but more radiation treatment. And then advanced stage patients, you would give just chemotherapy and no radiation treatment. However, even with the radiation treatment, some of the new drugs that I'm sure Sam will talk about in just a minute, we're trying to replace radiation therapy by utilizing those agents. And we've used PET scans as a way to tell us who might need extra treatment like radiation or those agents versus not. So you hear me having to hedge a little bit because I think a lot of it is individualized, and that's really the most important thing.
Absolutely. And how do you sort of decide if there are, because there's a couple different prognostic systems, right? So if somebody is unfavorable in one and favorable in two others, like how do you factor that in?
Yeah, so I think what you need to do is pick one system, because then you can really utilize the data that's supported by that system. So the German Hodgkin Lymphoma Study Group has done a lot of work in this space. And in our practice, we tend to use the prognostic system that they use, because that helps us be able to standardize our treatment. And I think what we really want to do is always push the envelope. So we encourage people to participate in clinical trials that are testing new ways compared to the standard ways, to see if we can actually optimize treatment even further.
I love that. And thank you for bringing up clinical trials. It's so important for me and to raise awareness in the Hodgkin community, lymphoma community in general, about the importance of being involved in clinical trials and knowing that you don't have to have failed multiple lines of therapy before you can consider clinical trials. Clinical trials can be for everyone. And there's so many different types of situations that somebody could need a clinical trial for. We're looking at things to de-escalate therapy or to, you know, um, alter treatments based on a patient's individual situation. So I think classically people think of clinical trials as something that you have to really be on like death's door, failing multiple lines of therapy before you look into something like that.
Well, I would say you're exactly right. In fact, the most impressive and important data that has come out in Hodgkin lymphoma is in the front line, based on recent clinical trials. So everyone needs to remember that what we do currently is actually based on people that participated in recent clinical trials that have changed how we practice. So standardly now we would utilize new agents like PD-1 blocking antibodies or brentuximab vedotin plus chemotherapy, rather than just chemotherapy alone, because that's actually improved the outcome of patients, and especially in advanced stage patients, that's now the standard of care.
Yeah, that's great. Thank you. And speaking of latest advancements in treatment, Dr. Grover, can you tell us about what are some of the newest, hottest treatments in Hodgkin lymphoma?
Talking to what Dr. Ansell said right now, I think probably the hottest advances in Hodgkin lymphoma are related to incorporating some of these new treatments to earlier lines of therapy, so to the front line, to really try to both improve outcomes, so increase chance of cure, and also to reduce long-term toxicities. And I think the two biggest drugs that have really transformed the care for Hodgkin lymphoma in the past, now almost a decade now, in the past 5 to 10 years, are brentuximab vedotin, which is an antibody drug conjugate. So basically it delivers chemotherapy specifically to the cancer cells. And basically the cancer cells in Hodgkin lymphoma have a marker on them, CD30, and that's pretty much universally seen in all the Reed-Sternberg cells, the cancer cells in Hodgkin lymphoma. And this brentuximab specifically targets those cancer cells in Hodgkin lymphoma. And then the other drugs are what people may have heard of other types of cancers are the checkpoint inhibitors. So these immunotherapies that really help the immune system fight the Hodgkin lymphoma. And incorporating these drugs, nivolumab and pembrolizumab and brentuximab, at first they were really successful in relapse refractory disease, and now are being moved to earlier lines of therapy, both to try to reduce the amount of chemotherapy that we're giving patients and also hopefully to enhance cure in these patients.
And how about some recent clinical trials for reducing toxicity? I heard about something called AHOD21, a lot of numbers.
So there's now currently a trial that just opened up, both for pediatric and adult patients, looking at whether we can incorporate these newer treatments, both brentuximab and checkpoint inhibitors, in newly diagnosed Hodgkin lymphoma patients. So everyone gets 2 cycles of standard chemotherapy, and then patients get randomized to either getting these new treatments, the brentuximab and the nivolumab, or continuing with standard treatment, standard chemotherapy. So the question is, by limiting the chemotherapy and radiation, can you improve outcomes for these patients? Improve both the one, of course, one one thing they want to look at, of course, is cure rates and long-term survival from a Hodgkin standpoint, but they're also collecting data very far out, looking at quality of life, patient-reported outcomes. So that's a really big component of this trial as well.
Yeah, that's incredible. And when you're talking about like late term effects or reducing toxicities, just so we have an idea, for patients who are newly diagnosed or might be trying to make some of these decisions, what are some of the things that we're talking about in terms of toxicities that we're trying to reduce in the long term?
So there's a few different things. So one of the things we're thinking about are one of the chemotherapy drugs that we give patients can affect their heart function. So some of the things that we think about later on are risks of heart disease for these patients, kind of looking way down the line. So that's one of the things that we consider is thinking about is risk of heart disease. Some of the other things that we think about, one of the drugs that we're using a lot less often now can affect lung function. So some of the other things we look at are also having issues with lung function moving forward past therapy later on. So other things that we're thinking about, especially with some of these drugs and using more brentuximab, are things like neuropathy. So patients can have some nerve damage and issues with either numbness and tingling, or issues with even doing some different functions like texting on their phone or typing or writing that can affect kind of moving on, or issues with pain from that as well. So those are some of the other things that we think about. And then other things that patients always think about, of course, with young patients are things like fertility. And even though as Dr. Ansell mentioned, many of these patients are able to have children in the future, and fortunately, a lot of these earlier treatments don't have as big an effect on fertility. It's still something we think about, especially if we need to escalate people who have disease that relapses or need more aggressive therapies. And then some of the other things we think of are secondary cancers. So some of the damage from chemotherapy may increase the risk of potentially having other cancers, or from radiation, and potentially also having leukemia from the chemotherapy. So those are some of the late-term effects that we think about. And I think the positive is that most of these patients are living long enough for us to really be able to focus on that and think about these effects. Obviously, the top priority, of course, is curing their lymphoma, but we also want to think about quality of life for patients moving forward and making sure that they live long lives from other things as well.
What about trials to reduce or resensitize to PD-1 drugs? That's something I haven't really learned that much about. What does that mean?
So basically, checkpoint inhibitors are some of the treatments that are really effective in Hodgkin lymphoma, and right now we're moving them earlier, but even before that, for relapse and refractory disease, these are treatments that can work really well for these patients. Hodgkin lymphoma is unique because as opposed even from compared to other lymphomas, there's not that many cancer cells for these patients, and most of the lymphoma, when pathologists look at the cancer, it's a lot of immune cells around their cancer cells. So there's not that many lymphoma cells. A lot of it's the immune reaction to the lymphoma. And so checkpoint inhibitors help treat patients, the immune system actually fight the cancer. And some of the issues that some of these patients may stop responding to checkpoint inhibitors. So there's interest in using other types of treatments as combinations. So even if a patient may progress on pembrolizumab or nivolumab, can you combine them with other treatments that can kind of resensitize their immune system so they can now be sensitive to these treatments too. So there's some research looking into that. We've also seen that patients may get, I guess, the reverse, that these treatments may also reset the patients in some way, and patients may get checkpoint inhibitors and then after that may respond better to other treatments. So there's been some studies showing that patients after checkpoint inhibitors seem to, even if they progress on those drugs, they potentially respond better to chemotherapy or other treatments after they get those drugs too. So yeah.
So we're still totally learning how
Yeah.
these drugs impact the immune system and how they might make you respond better to
Yeah.
traditional chemotherapies, even if you didn't initially. And
Yeah.
we're just still figuring all that out. Wow, that's incredible.
The current biggest advances right now are in Hodgkin lymphoma advanced stage. More recently, brentuximab was incorporated to the advanced stage Hodgkin lymphoma in addition to chemotherapy, and improved, and Dr. Ansell was part of that study, but actually improved overall survival in advanced stage Hodgkin lymphoma patients compared to standard of care.
Dr. Ansell, can you tell us about SWOG S1826 trial and what that means, what that showed?
Yeah, so I think really just kind of picking up again on the theme of better therapies, getting better outcomes, and using some of the new drugs that we've touched on. Um, as Dr. Grover said, our kind of management of advanced stage patients has kind of moved over time. Back in the day, we just gave chemotherapy, and we used to try and leave out the drug called bleomycin that she mentioned will cause lung toxicity if patients were doing well based on PET scans. But as these new drugs came along, brentuximab vedotin being the first one, and as she mentioned, it's an antibody drug conjugate that sticks to the CD30 on the cells, that was brought into the combination in the place of the bleomycin. So it was now brentuximab with AVD, no B. The B was dropped out. So that was compared head to head and showed that the brentuximab improved the outcome of patients, not only their likelihood of staying in remission, but actually their overall survival. And then, to your question, that was then compared as the standard to nivolumab, the PD-1 directed therapy plus AVD chemotherapy in the place of bleomycin. And as you heard us touch on, that then showed a progression-free survival at a 1-year follow-up. So we don't have mature data yet, but it seemed better already than the brentuximab AVD chemotherapy. And as Dr. Grover touched on, less in the way of side effects and better tolerated. So that's really likely to become the new standard for advanced stage patients. And I think, again, we want to just see a little bit more mature data, but certainly in the elderly patients where toxicity is a real challenge, this has actually become, I think, a standard for many already. So I think we can see the progression from old style chemo now to immune checkpoint plus chemo as the frontline treatment.
These are really exciting times. It's wild because, and I said this on the last Hodgkin program that we did, that for decades and decades, it seemed like there wasn't, like it was sort of the same thing that we were doing for Hodgkin patients. And then in the last 5-10 years, wow. Even if I were diagnosed, my exact same clinical scenario now as compared to 2021 when I was first diagnosed, I would be treated differently presenting with stage 2 AE. Could you tell us about these clinical trials and sort of what gaps do they fill just to bring home the learning points?
I think you heard us talk about these 2 new drugs. They kind of came from the relapse setting, but have moved all the way up now to more frontline treatments. So the gaps are now for patients, heaven forbid, that have gone through these new therapies, and there is still a subset of people where the disease proves to be very challenging and keeps relapsing. Now that's getting to be a smaller and smaller group, so that's the good news. The challenging point is that it's never good enough until there's nobody in that group. So we still see patients that have gone through this standard treatment now using these new drugs, and then the disease comes back yet again. So things that are becoming exciting and things that we need to do better on is what to do in those patients. And so additional treatments that target these other immune checkpoints, aside from PD-1, which is one of the focuses that we just spoke about, other ways to make the immune system wake up and do its job, those are being tested. And then the work that Dr. Grover and her team does is really taking your immune cells, sending them to, as it were, training camp to actually get a little docking site on them so they can detect the cancer in a much better way, and then unleashing them on the cancer. That's proving really exciting. And then finally, what we call bispecific antibodies, they grab onto the cancer cell and they grab onto the immune cells and they go, hey, this is what you're supposed to be doing. You need to fight this cell. Those are also being tested. So those are some of the exciting opportunities in the future.
Yeah, that's incredible. I mean, this sounds like science fiction. Can you
It's
tell
still
us?
science fiction, except it's here right now.
Yeah, that's great. It's wonderful. Can you tell us about bispecific antibodies, a little bit more about that?
So this is an area that's really growing really fast. In Hodgkin lymphoma, you heard Dr. Grover talk about CD30, which is this protein on the outside of the cancer cells. So the antibody is directed on its one arm to CD30, but on the other arm, it grabs onto CD3, a different protein on a different cell. So CD3 is typically on T cells. So what it does is it brings those cells into very close proximity to each other. And just a little bit like your kids in the back of the car who don't like to sit next to each other and keep kind of poking each other, this kind of causes those cells to be grumpy with each other, and T cells, your immune cells, will then fight the cancer. That's really what you want to see. One more way in which these bispecifics are being done, you heard us talk about these immune checkpoints to make T cells do a better job. So one of the ways we're doing that is now on the one arm, PD-1, which is the now established immune checkpoint, but on the other, something like TIM3, which is another immune checkpoint. So other ways in which T cells are being switched off are now protected. So it's just making those cells even more efficient. So those are two of the main ways bispecific antibodies are being tested right now.
Thank you for that. And Dr. Grover, how about CAR T cell therapy and post-transplant relapses? Can you tell us a little bit about that and where that might play a role?
Yeah, so CAR T cells, Dr. Ansell briefly mentioned that's basically taking a patient's own T cells, setting them off, and then re-engineering them so they can specifically target the protein on the cancer cell and that CD30 that we talked about. These CAR T cells, we have a trial of that at UNC, and there's also has the trial at Baylor College of Medicine. So there are two academic trials where we're studying these CAR T cells in patients with Hodgkin lymphoma. There's also a few trials internationally. I know there's a group in Spain also doing work there, and also a group in China. So there's a few centers doing this research. But unfortunately, right now there's not a company sponsored trial. So they're really exciting treatments, but they're not as easily accessible, where patients do need to travel for these treatments. And we do right now, the big thing have long waiting lists, but are hoping that we can get more patients treated more quickly, because it definitely still shows that there is an unmet need. There are these patients who have not responded, progressed after brentuximab and progressed after checkpoint inhibitors and progressed after transplant, and need additional options for treatment. And with CAR T cells, we have seen some really nice responses in patients who've progressed after many different whose disease has progressed after many different therapies. But there's still work to do to improve these therapies. Right now, we have some patients who have been in remission for many years, and 5+ years in remission after getting CAR T cells, but there are still many patients who get the CAR T cells, have a great response, but still then their disease relapses afterwards. So we're trying to figure out why that's happening and how we can improve the CAR T cells and improve outcomes for patients.
Sam, there's one other option which takes both bispecifics and cellular therapies and kind of combines those strategies. That's actually taking cord blood, so cells that are the natural killer cells from cord blood, and using a bispecific antibody that targets again CD30, but now a different protein called CD16 on the NK cells. So it sticks this bispecific antibody to the NK cell, and they pre-treat the NK cells before they give them to the patient and then infuse them in. So it's a little bit like you activate the cells outside the body, you add the bispecific antibody so that it's already stuck to the NK cells and infuse them. And those also have been effective therapies. I think Dr. Grover's right. We're still learning about how many treatments you need to get. They're getting high response rates, but the durability is still a little bit in question. But I think that's another exciting strategy of taking cellular therapies and bispecifics and using them together.
I was just going to say that one's, I think, the Luminice trial, and that's open at that's going to be open at several different sites across the country. So that one will be available at many different institutions, hopefully soon.
That's great. That's an important point. And it's part of the issue that just Hodgkin lymphoma compared to non-Hodgkin, it's just not nearly as common. So it's in terms of people, the amount of people that will qualify for these trials, that may be why they're less commonly offered.
Yeah, and higher cure rates, and less common. And I think the other part of it, which I think is a partially good thing about Hodgkin lymphoma, is that a lot of times patients with relapse disease can, as opposed to some other more aggressive types of lymphoma, those patients that can be more aggressive. But with Hodgkin lymphoma, patients with relapse disease oftentimes can live a really long time. So even if they have disease, I've seen patients on my trials who have had disease that's been relapsing and maybe not even really been in remission, but have been living for 10 years, for many, many years with relapse disease. So a lot of times these patients may, which is a good thing, they may not be as sick, and then they're able to be part of these trials. They're able to travel and able to participate in these trials, able to wait to get to these trials, because there's so many of these patients that may be alive and doing well, even though they're going through treatments or have some disease left. So
Yeah, absolutely. And then where is all this in relation to allogeneic transplants for people who are relapsing after a transplant? Allo meaning like the donor is coming from somebody else as opposed to auto, which is more common of a situation for transplant in Hodgkin.
So I think, to be honest, allogeneic transplant is still a curative option, and so something that we would always consider. It's a little bit high risk because of the potential for longer term toxicities. So we spoke about toxicity earlier, and that's something that you'd have to weigh up as you're thinking about it. And then I think with a lot of these novel treatments, many of which have been very successful in the past, people kind of delayed allogeneic transplant a little bit. As we mentioned, there's some challenges now as patients are having their disease come back, the small minority where that's true after standard treatment. And so there are a subset of patients for whom that needs to be considered. I think that's a very individualized discussion between patients and their doctors, weighing up those risks versus the benefits.
And just a brief touch point for Dr. Ansell on what are some of the developments in salvage therapy, meaning if when somebody's had their initial relapse.
Yeah, so that's a very good point, good question. It's actually a moving field pretty fast right now because, as we mentioned, novel drugs are being used in frontline. So one of the key questions always to ask is, what treatment did somebody get as their first line? Because that really impacts what you would do in the second line. However, I think based on where most patients are right now, not very many of them have had an immune checkpoint treatment. That's the nivolumab and pembrolizumab that Dr. Grover spoke about. Not too many people have had that as their frontline treatment. So for many, using those in combination with standard chemotherapies, and those are combinations like ICE chemotherapy or GVD chemotherapy, and then in the majority of particularly younger patients, going to a more intensive treatment and a stem cell transplant using your own cells is very much the standard management. And some interesting recent data compared people where that was used compared to even just standard chemotherapy or the use of brentuximab and chemotherapy, then a transplant, and then looked at outcome. The patients with the best outcome got a PD-1 antibody before they got their transplant. And Dr. Grover touched on this, which I think is an important point. It seems this PD-1 blocking antibody team seems to change the immune system a bit and make patients more sensitive to some of the chemotherapies after the fact. So that's why it seems like it makes a difference. So we tend to favor a chemotherapy with an immune checkpoint therapy as a treatment approach before going to transplant.
That's really interesting because I know in other cancer processes, people will sort of save therapies or not want to expose them because the body will learn it. And so what you're saying is that sort of principle may not apply in Hodgkin, that these therapies may actually sensitize to other therapies or make people respond better. And so you don't necessarily need to leave them until later when you've burned through other options. And
correct. And I would actually say, to be honest, we want to see people cured. So bottom line is that I think my recommendation to patients is, heaven forbid that it comes back the first time, but and if it does, all the gloves are off. Now we're going at it as hard as we possibly can. And we want to utilize all the effective tools that we have so that we can truly kind of beat it into the ground. So that's kind of what I would recommend. Different to other cancers where you might want to string things along in a palliative approach, I think you want to go after this with a curative intent.
it's wild to think how quickly things evolve, and maybe how important it is for patients to seek out providers or treatment at cancer centers who have some connection with the trials, who are able to know sort of what are the latest updates. Like, how can we advise our patients to be able to seek out that kind of care? How can they ask for that from their oncologist who may be getting treatment in the community or things like that?
So I think, one of the important things, and it sounds like you were exactly that sort of patient, be an informed patient, be a patient who asks questions, be a patient who is a strong advocate for yourself. And so what ways in which that can be practical is there are really good resources. Leukemia Lymphoma Society have really good information related to many of these topics. And so I think being informed about what's the best way to be managed, I think, is useful. When your doctor sees you and goes through things, asking questions relative to the information that you have helps you feel really reassured that you're on the right track. But I think most of us are quite okay with patients getting second opinions from other colleagues. That just helps people reinforce the messages you're already giving, so that I think people will be very comfortable doing what needs to be done if they're hearing the same thing from more than one person. So I think all of that pertains to a good outcome. If you ask questions, make sure you get your questions answered.
Thank you for that. Thanks for empowering patients, because yeah, it's so hard to make these decisions even when you have a lot of resources and all that, a lot of education. It could be such an emotional time in addition to perhaps not feeling well. And so it's helpful to hear that from the people who are doing the trials, doing the medicine, that you expect people to want other opinions and to be informed in the information Google era.
And I think, to be honest, a lot of patients come in and they get so much information that it's pretty challenging to retain it. So I always tell people, bring friends or bring family and have other sets of ears who can help reinforce maybe some of the messages that when your brain just locked down and you couldn't think straight, they heard things that you might have missed.
Thank you. Dr. Grover, can you tell us some final points or takeaway messages?
Absolutely. So I think the biggest things, and when thinking about Hodgkin lymphoma right now, the biggest advances, or the biggest exciting things that I'm excited about are reducing toxicity with improving our earlier therapies. So moving these newer therapies to frontline and to really reduce, both to hopefully enhance cure, so prevent patients from relapsing again, and also reducing long-term toxicities and improving patients' quality of life. And then the other thing is that there's still an unmet need for these patients that are refractory to checkpoint inhibitors, these newer therapies, the PD-1 inhibitors and the brentuximab and chemotherapy. And there's still really an unmet need for those patients. And I'm hoping that over the next few years, we have more clinical trials and more developments for that patient population. And I think for patients, I think the biggest thing is, coming in, asking questions with your provider. Don't be shy about getting a second opinion if you want to feel comfortable. I'm never offended if a patient goes for a second opinion.
Thank you. How about you, Dr. Ansell?
I think the takeaway is that, it's, if you're a patient with Hodgkin lymphoma, there are unique and novel treatments that are making a big difference to patient outcome. And the treatments are getting better all the time. So I think there's a lot of hope for the fact that I'm hoping that in the not very distant future, every patient with Hodgkin lymphoma can be cured with frontline treatment.
Thank you so much for that. On a personal note, I just remember thinking initially, like, just I was scared about death and dying. I think that's what a lot of people think about when they hear the words cancer. And then once it began to move away from that, and it began to become, you know, living with cancer or living life after a cancer diagnosis, it was like, well, I'd like to still be able to jog and to paint and to play guitar with my hands and to hold my kids and to be able to think as well as possible in terms of the brain toxicity and stuff. So these trials that you guys are doing to improve quality of life also while simultaneously, improving outcomes with the cancer. It's so meaningful personally to me. And I just really appreciate it. I know it means a lot to our patient population that you took the time to have this conversation with us today. And thank you so much.
My pleasure.
All right. Well, I want to thank you all three of you doctors tonight, Dr. Sam Seigel, Dr. Angela Grover, and Dr. Stephen Ansell, for this enriching conversation. We know how busy you are, and we don't take it lightly that you spend extra time to be with us and our community. Now, don't forget, those of you who are watching, your voice is so important to us. What do you want to hear about? What were your thoughts about the program? What can make this better? That is what you can do in responding to a survey that is going to pop up after this program closes, and it should just take a few minutes. We also hope that those of you who watched enjoyed and learned from this discussion, and we have more for you. So don't forget to check out thepatientstory.com for more patient stories and programs and content, to lls.org for the incredible resources there, like the information specialists and the clinical trial support nurses who help navigate in that arena, as well as ImmermanAngels.org for the peer-to-peer support program that I mentioned at the top of the program. We will have the links to all of our partners and to our own resources in a follow-up email. So thank you so much for joining us. We hope you have a great rest of your evening and hope to see you at a future program. I'm Stephanie Trong for The Patient Story. Take good care.